Well, good afternoon. Thank you for all those that joined us this afternoon on this webinar. I'm Shane, I'm Concept Advisor and very privileged to be hosting this webinar on behalf of Spacestor Healthcare this afternoon. So to give a bit of background to anyone who's not aware of Spacestor Healthcare, just before we go to today's webinar. So Spacestor Healthcare, as a background, is a manufacturer of workplace furniture, and we've learned from our engagement over the last 30 years with larger corporate global companies and how they've been defining their workspace strategy, and working with companies such as Google and Roche Diagnostics and Pfizer, how their workplace and the needs they have in there have really mirrored within the healthcare organisations over the past few years as well, mainly since the pandemic. So we've been working with NHS trusts on working with outpatient transformation, how we can create spaces that are needed for the transformation programme, and things such as modular acoustic pods for remote consultations. So we really wanted to expand this transformation journey with our clients and stakeholders involved, and have been running a insights series of webinars. And today we really want to focus on outpatient transformation and what can we do to bring in results now. So we know the problems that we need to tackle, and what can we do really this year rather than being a future goal that we can bring in some results within outpatient transformation. So as I said, I'm co-hosting this webinar today with my colleague Alex. So maybe just like the panelists to introduce themselves. So maybe Martha, if you'd like to introduce yourself first, please.
Of course. Afternoon, everybody. Thank you for joining. So my name's Marcia Lewis, and I'm a director for a healthcare consultancy, Productive Partners. My background is I've been a senior manager within the NHS for over 10 years, working with many different trusts nationwide around transformation, change, and making, efficiencies within outpatients, within theatres, etc., and really quite passionate about, the digital innovations and kind of maximising what we currently have. So really excited to be on the panel today.
Good, thank you, Martha. Very glad to have you on board. Michael?
Thanks, Shane. So hi, I'm Michael. I'm a NHS doctor by background. I've worked for the NHS since I was 18 years old. I still practice clinically, and I'm also the Associate Chief Clinical Informatics Officer at Derby and Burton NHS Trust. I also wear a few other hats. I'm a founder manager of a SME that manages digital health flow and NHS ready software, as we call it. And also on the Clinical Entrepreneur Programme as a mentor. So yeah, pleasure to be here today. Thanks for having me.
Good, thank you, Michael. Good to have you on board too. Bharti?
Oh, hi guys, I'm Bharti Malhotra. I work as Senior Improvement Manager for Incentive for Innovation Transformation Improvement. My background is in Ops, Improvement, Research and Transformation. I've been in the NHS for 15 years. Very much looking forward to sharing some great learnings we've had in some of the transformation works I've been involved in.
Good, thank you, Bharti. Good to have you on board and look forward to sharing those insights. Good, so thank you, and thanks for all those that have joined today. For those that are just joining on now, whether it's through the Teams platform Wellington Live, thank you for joining. And as we go through the presentation, we would like to encourage you to ask questions as we go along, and we will try and answer them. So please do put those in and we'll forward them to the panel. So coming back to the topic today of outpatient transformation, how can we boost results? I thought maybe it'd be good just to, I don't know if Bharti, if you've got some maybe initial thoughts on some of the work you've been doing at your trust, and maybe some things that you think that have stood out over the past year or so that you think have been beneficial.
Sure, Shane. So just to give you a bit of context, so I'm talking about context in terms of Guy's and St Thomas's, but I'm sure this is a generic message and a problem that NHS trusts are facing across board, which is hundreds and thousands of patients waiting for outpatients appointments. So what we did in the last year was we developed a clinical rule sets and working with an external company to digitally prioritize these patients as to where they are in terms of their risk stratification, and helping the tool to prioritize patients who might be having harm, who are suffering harm because we're not seeing them on time and bringing them forward. at the same time using this opportunity where the patients are flagged as low risk to put them on low intensity pathway. So that's been, emerging results have been quite encouraging, and it's we're particularly doing it in diabetes service and now expanding to cardiology, rheumatology, ophthalmology, and few more services within Guy's and St. Thomas's. So and this is the first time I think as a trust we've done risk stratification in outpatients so successfully. So I think that's something I would say is worth considering if you haven't looked into that model yet. So I'll pause and take questions when we're ready.
Yeah, no, that's good. So we're able to streamline the pathway.
Yeah.
Is what you're talking about. So factoring that in. Marcia, have you got any comments on your experience within that area, or sort of streamlining those processes?
No, I think just homing in on what Barty said, I think for trusts that have, the funds to be able to put in innovations like that, it's fantastic. But also just using what they do currently have. Some of the work we're using with trusts at the moment, a lot of trusts have two-way text messaging systems in place, and actually looking at doing a bit of validation around the outpatients waiting list. So I know typically that's something we do for like the elective list to see if patients still require surgery. But a lot of patients have been waiting a long time for outpatients. So just similar to what Barty said, really trying to make sure that actually if trusts have the ability, sending text messages out to patients, or, calling some of those patients that, have been waiting on the outpatient waiting list and seeing if they still require an appointment, and seeing, actually how severe is the situation for them? Is it low risk? Is it high risk? So that we can make sure we're putting on appropriate capacity for those patients to treat them. And I think, just using all the tools that you have in your arsenal is definitely something to consider.
Yeah, that's good. Thank you, Marcia. Michael, have you got any comments from your background on that?
I guess just to reinforce the things that have already been said, really, and just to, because I like to think of these things simply, right? So we operate in the waiting lists on a single road effectively, and what we've now got is a massive traffic jam. So this stratification of risk that Barty sort of outlines, where we identify low risk, the slow moving lanes, and the high risk, the fast moving lanes, and take it to a motorway instead of a country lane. I think it's the only way that we are going to be able to cope with the backlog. And just on some of those initiatives, really, yes, digital is a massive step forward, but we're even seeing some sort of things like patient initiated follow-up. There are initiatives out there that aren't necessarily wholly driven by digital. Obviously digital makes it more efficient, but there is always going to be ways where we can become more effective in managing working sort of waiting lists, and obviously allowing patients to initiate their own follow-up was one of the ways that I think was a really good example of a small step towards a bigger solution.
Yeah, absolutely. And I noticed, I think it was on LinkedIn, you did a post the other day about efficiency. That word I thought was interesting. You have some comments on that, on sort of.
I literally changed my word in midway through what I just said. So yeah, I mean, I in a nutshell, I said that we are working towards, this is our organisation, but many organisations, Spacestor as well, are working towards a more efficient NHS. And by efficient, what we mean is being able to support more patients in less time, but at the same quality. And I was challenged that actually we should be using the word effective and not efficient, because some people shy away from the word efficient as being an economic driver, and so value for money, as opposed to actually focusing on patient safety. And I said, well, if you deliver a service faster at the compromise of care or safety of care, then actually the overall efficiency remains the same. If anything, it gets worse, right? Because you're now having to mop up all the mistakes that were made, all of the harm that's been caused. So when we talk about efficiency in healthcare, what we really mean is being able to support more patients, or support patients in less amount of time, but at the same level of quality and safety that we expect of the NHS as a standard. So I think it was a really nice conversation that I had around the definition of efficiency in healthcare. And obviously we're moving towards a more efficient healthcare because we're finding new ways to support patients in a more effective way.
Yeah, no, I think that's good. It's good to have that clarity around what we mean by efficiency, and I thought that was helpful, so thanks for sharing that. Barty, have you got any sort sort of
Yeah.
insights from the sort of efficiencies you may have brought in your
Yeah.
experience?
Sure, I think, and also Michael raised a very important point on involving patients and giving them, putting patients on patient initiated follow-up pathway, etc. I think I don't know about every trust, but in our trust, there's a slight catch-22 there because we're not seeing these patients in the clinic. We can't have this conversation to say, can we put you on PIFU, and next time when you need us, call us. So I think this is where this tool that we have developed is very useful, because this will allow us to identify patients who are potentially suitable for that conversation to happen, which can happen on a telephone, doesn't need to be having a face-to-face, more expensive, resource-intensive appointment, which is coming back to Michael's point of driving efficiency. Efficiency is about how do you deliver the similar or better outcome at less cost. So this is like, yes, you can still do it. Patient has never not traveled, so it's most economic for them. But we are doing something safe and they are agreeing to this. So this is definitely, there's a lot of potential, and we are developing that model specifically in long-term conditions, diabetes and vital 5 within GSTT.
That's good. And in terms of over the past years with clinicians, how have you worked with them? I know obviously one of the barriers has been around clinician sort of buy-in to maybe the change within outpatient transformation and remote and virtual. How have you managed to tackle that?
So risk stratification in outpatients has been a topic. It's been, at least I've heard it for like nearly 7 or 8 years. And COVID only made it more obvious that this is something needs to happen. So I think one of the advantages of rolling out risk stratification has been there's been an automatic clinician buy-in, because this was a lever to say we have kind of left it for too long, we can't do it anymore, let's get our act together. So if anything, I think one of our strongest points in our program is clinician buy-in. Our main barriers have been people are doing on top of their full-time job. So everybody who is involved, this is like their second job. So that's been our barrier. Plus, like, our trust is going through a major digital transformation program with the rollout of new system. So we kind of so it's just we're spreading ourselves very thinly, and that's been the major barrier. But there's a huge desire to move forward with this.
Yeah, that's good. Thanks, Bharti. Sort of moving on, I was thinking of the topic of did not attend, and that I think, Martha, we had a few discussions around this before, so maybe you've got some insights you could share on that.
Yeah, absolutely. I think that ultimately we're trying to reduce and avoid the did not attend. And I think we had a really good conversation yesterday about understanding what's driving that. It's not always that patients don't want to come, it's that some patients don't have access to be able to get in and various different things like that. But I definitely think that one of the things that I noticed working in trust sort of nationwide is actually how we're booking appointments. And it's like I said, if we're booking a follow-up appointment for 2 years' time, and giving that patient the appointment 2 years earlier, I mean, most of us would forget that, and you know, could slip through the net. So it's thinking about using systems like partial booking, which would then mean that actually you don't book out any more than the 6 weeks, which allows for less changes to happen. I think in one of the trusts that I worked in, a patient complained actually is how it came to the forefront. But because they were booking so far in advance, this patient had their appointment moved 14 times, which is a really poor patient experience. So actually, how do we try to book appointments closer to the time? Also making sure that we're calling patients, you know, giving them choice again. What choice are we giving them, and how are we putting that back on them to be able to say, actually, these dates work, these days don't work, tapping into virtual and digital as well. And simple things like just if you've got the facility and the capacity within your team, sometimes actually if you are booking that far out and you don't have the option to do partial booking, creating something like a 5-day call out system, you know, supporting your text messaging as well. Yes, we have text reminders, but if we can have people that are just, you know, focusing on some of those really high DNA clinics and calling patients to confirm they're coming in, all these types of tools have seen a benefit and have definitely seen DNAs decline within certain specialties and trusts that we've been working with.
Yeah, it's good. Michael, you got some comments on that as well?
Yeah, I mean, we could spend an entire webinar talking about the DNA issue within healthcare. I think it's a grand challenge, really, and one that I don't think is easily solvable. But there are innovations in the pipeline. There's things that I'm working on with a number of NHS trusts, industry partners, to actually look at how do we reduce and prevent that down. One of the interesting things actually is there's we see correlations in DNAs, and we think we know the type of individual that might not attend an appointment, but we don't actually capture that data very well. So one of the things we're looking at is actually who's not attending and why aren't they attending. We can ask questionnaires, we can do market research, but actually, is there an easy way to capture that data? So one of the things we're looking at is actually asking people that don't attend, why didn't you attend? What can we do better next time? Putting the onus back on the NHS Trust to understand, is it traffic at a certain point in time where we might need to reallocate resource at different times of the day so that people can attend, because why are we having appointments 5 till 6 if no one can get into the hospital? So it's really looking at using data, insights, feedback, obviously appropriately, but using it so that we can better make decisions around how we facilitate a service within a healthcare setting. So that's one of the things. And again, it's about behavioural change as well as for populations. There is another study that showed that 19% of patients within a cohort of within a GP practice didn't attend more than one appointment, and through multiple different specialties and problems as well, complaints, symptoms, whatever you want to say. So actually, there is a reoffending culture in DNAs that can be easily supported to not repeatedly not attend. So obviously, the ways that we can do that is offering them the ability to have a virtual consultation. Obviously, that was a big step forward through COVID. Being able to educate them around the cost of what an outpatient appointment actually is, and that there is a cost attached, regardless of them not actually transacting money. So I think there's a lot of opportunity to educate, but there's also a lot of opportunity to innovate, and that's certainly an area of interest for myself.
Yes, no, yeah, appreciate that. And it's not that we will have the answer, but that's some good insights to share on that. Barty, have you got any insights from your work on that?
Sure. So since you put me on the risk stratification lens, I will probably share how we use risk stratification to manage DNAs in outpatients and what our proposal to the services is. So what happens is, yes, patients are DNA. What happens next? So what happens is specifically trusts who are not following access policy strictly, which is one of our trusts, because our patients are complex and it's not the right thing to just discharge them without understanding why they didn't turn up. So the model that we are proposing, and we've kind of trialed it in some services, is how do you use risk stratification to actually offer the next level of care for patients who have DNA'd? Because at the moment, it's like just offer the next one, next available. We're just shifting the backlog. And services that we are working with, they have got 4-5 months of follow-up waiting lists. So we are encouraging clinicians to use the tool in the clinic to say, if this patient is low risk, you don't need to bring them like face to face. To consider doing a virtual, as Michael and Marcia suggested. Maybe that's a more appropriate, and maybe there will be less DNA, because at least you will have some conversation with the patient. So and we have heard very encouraging we have had very encouraging engagement from clinicians on that. And also it's saving a lot of admin time, because sometimes admin are left with pile of these DNAs to deal with, and they're just randomly booked everywhere, all over the place. We are stuck in this really self-perpetuating problem. So again, so that's my response from the risk stratification lens, would be to consider.
Yeah, that's helpful. And on that sort of point, how and this is sort of to all the panel as well, sort of how we do we manage that capacity issue that there may be, so obviously and the workload, I guess.
I was going to say, I mean, it is a challenging one, I think, because as Barty kind of said, a lot of this work that's being done is on top of their core sort of job plans and what they're already allocated to do. I think really it comes down to really cleansing and understanding the priority of the patients. And again, like Barty said, understanding you know, they're high risk or low risk. How can we manage those patients in a virtual way or face-to-face, and really just trying to make sure that patients who are waiting still want to be seen. I think the worst thing for any clinician is to have a patient come in only to say that actually they don't have a problem anymore, or actually they don't feel they need to be seen, because actually that's an appointment that could have been given to a patient that did. So really just that validation piece, and kind of wherever you can, trying to make sure that the patients who are coming in need to be seen, can just create that, again, that sort of opportunity for the capacity to be managed better.
Yeah, no, yeah, absolutely agree. And so going from that point in terms of virtual consultations, and the fact that we all know that obviously virtual has to be part of the process now, going sort of back to more face-to-face won't help us achieve the backlog, but how realistically can we help increase the sort of virtual take-up?
I think the problem is that we've got a I think digital and innovation is the only way, and automation you could probably throw in there as well, is the only way that we become more effective at being able to manage these issues. The problem is that the workforce that we're asking to support with this are already at breakneck speed. In fact, they're overstretched. So we're not giving the people that need to be able to trial, test, implement these solutions the breathing space that they need to be able to look at the long-term vision. So they're firefighting day to day, managing clinical services. I've been there, and so you don't have that headspace to be able to say, actually, if I took half a day out of my week to be able to think about new innovative ways that we could manage the backlog, perhaps in 6-12 months time we have a more efficient service. But it's being able to free up that time that we aren't able to do, because again, lots more patients, big backlog and waiting lists, not enough staff. So it's a really complex ecosystem at the moment in the NHS, and I think it's going to remain that way. One of the things I think we can do is, obviously we've got a lot of people within organizations, sort of CCIOs, CIOs, digital nurses, allied healthcare professionals that are now able to spend time thinking about new ways to manage processes and things like that. So it's getting their buy-in to an idea, a solution, whether it be internal or whether it be a procurement process, and then enabling them to actually take the time to demonstrate that actually, yes, we're going to have to spend X amount of hours over the next 3, maybe 6, maybe 12 months, but actually the long-term gains over 5, 10, 20 years period is that we see this many more patients, we prevent this much more harm, we get to diagnose patients faster, we get to treat patients faster. And so unfortunately we have a very, we struggle to look any further than next week for a lot of healthcare professionals, because they're just so busy. So I think sometimes it's like saying that a fish can't see water, the Chinese proverb. Sometimes it takes external people to actually look at the ecosystem and solve those problems, and so again, it's not something that's easily solvable, but we are moving in the right direction by introducing innovation, new technologies, automation, to be able to support a very stretched workforce.
Interesting your comments there, Michael. Have you seen any either challenges or barriers that have impacted on this in the area of access to technology? I'm thinking particularly for patients in deprived areas, and either access to the devices themselves, smartphones and that kind of thing, or access even to the internet. Have you seen that as a barrier or something that's having a negative impact?
It's a difficult one because, but it's a good question, Alex. So there's research underway around demographics and things like access to healthcare, DNAs, and things like that. That it's not always a direct correlation. So that we know that some people, for example, if English isn't their first language, there is less accessibility to things like information around an appointment. So if I get an appointment letter that's in English, if English is my first language, in fact, if I don't speak English at all, which some of our population don't, so that instantly puts me at a less. I'm more likely to not attend that appointment, right? And that is just what research has shown. So there's not a direct correlation in terms of the indices of deprivation and attendance, but what we do see is obviously that there are barriers to accessing healthcare services. You know, being able to afford to get a bus or a taxi to an appointment is always a challenge, right? So how do we support them? Well, we offer up opportunities to have a phone consultation, a virtual consultation. Then you've got the challenge of is it in the right language? So yeah, I think what we see is that there are many challenges across multiple demographics, and you know, because we have such a diverse population, it's another grand challenge to be able to accommodate for everyone. But again, another benefit of digital, another benefit of virtual, another benefit of automation is that we can start to think about new ways to support the people that otherwise, you know, generally will receive a letter and not be able to actually follow up on that appointment so that they do attend next time. You know, there's another thing around being able to, you know, anxiety, for example. Some people don't attend appointments because they just don't like the hospital environment. It's scary, you know, it can be quite anxiety provoking. So actually just being able to visualize that appointment and being able to almost go like a Google Street through a hospital. There's innovations like that where you can pre-schedule where the lifts are, for example. If you're a wheelchair user and you need accessibility, you need to know where that is. So again, we are moving in the right way. Could we be moving there faster? I'd like to think we can always move faster towards a more accessible healthcare system, but what we are doing is obviously, you know, we're still met by barriers, and that will always be the case. So it's just breaking those down and continuing to move towards a more accessible healthcare system.
That's interesting, and a question that's come in that kind of relates to what you're saying from Sharon, around the use of translators, language line or something like that to support, particularly where it's known in advance. I don't know, Bart, have you got any experience or comment around how that's working out in practice?
So I haven't got a recent experience, but yes, it's a tool which is available in our trust, so you can dial in and it's quite easy to access. But I'm not that close to that level of detail. I think the issue what comes up most frequently is the clinician do not know the patient has a language barrier. That information is missing in the first place for them to say, let's book an interpreter, or let's put language line in place, which means appointments they will arrange, but it takes longer. So that's an inefficiency that needs to be taken out. I'm just trying to pick on some of the points that Michael and yourself raised, Alex, about correlation with use of technology and low IMD index. So the work that we're doing in recertification, we've actually found a correlation that the patients who are high risk and the patients who actually tend to DNA, and the patients who where a disease is particularly prevalent, especially the long-term conditions, they do belong to low deprivation index areas. So although I'm only talking about the services that we are looking at, but the data that every time we're looking at the data, this is becoming more and more stronger correlation. An answer will be different for each service. Yeah, so the literature obviously is more kind of geared towards long-term conditions, towards and low deprivation, because these patients don't look after themselves very well. They can't travel to hospital. They are stuck in catch-22. Hence, looking at the pathways that we offer from our services, and who do we offer that pathways to, and which needs can we cater to through this pathway is the basis of any improvement or transformation, as Michael was alluding before. And also where you can take waste out of the system to make it more efficient. So just telling you like very specific example, I was working with a service, it was just before COVID. We looked at a pathway which had 17 steps that a patient follows on the day. Too many steps for a patient. They were in that area for like 3-4 hours. That was totally an unsustainable model. Just by working closely with the team and taking the waste out, we reduced the steps from 17 to 10. So none of that was rocket science. It was just putting people together in a room, doing that facilitation, things that they have been thinking for so long. Think, what is it that you can implement straight away? And in my experience as transformation manager, there's always something that's straight away implementable.
Can I just respond quickly to the language line question?
Go ahead.
I think obviously language line is a good example of where a solution solved a problem. It enabled us to be able to have conversations in other languages, but that's where the kind of we've moved to another space where it doesn't solve problems for other means of communication, text, letters, things like that. And so I agree. I think there's obviously language line as well has to be pre-scheduled, or it has to be called there and then, and can be quite costly. So I think obviously we need to think about sustainability and scalability as well with everything we do. You know, how do we actually do something that doesn't require someone to sit on the other side of the phone and speak in a different language? Because again, there's a cost attached to that. There's a resource burden attached to that. So again, it's thinking about more efficient ways to solve problems, more scalable ways to solve problems. The language line is certainly a good example of one of the ways that we've moved to a more accessible healthcare system.
Thanks, Michael. That's helpful.
A couple of interesting questions coming in about the topic we were just talking about, the economic impact, deprived areas and access to healthcare. Saran is asking about whether the patients can't afford the extra expenditure to get to the appointment. Have you seen any kind of partnerships, either private partnerships that are offering transport services that can help address that specific issue? Marcy, anything you've seen on that area?
So, oh, sorry.
Go on, Marcia.
I thought you heard you say my name, Alex. So I was going to say actually, but actually in a trust that I used to work with in the Midlands, actually, it was driven by somebody locally who understood that there was a need within the area and kind of took it upon themselves to kind of support patients with that. But then because the hospital were aware of that individual, kind of procured them and offered that service to them, that actually if they were willing to travel and help patients get to their appointment, that they would kind of use them as the conduit to do that, which I thought was really nice because it's kind of in the community itself and people understanding the need. And I think the reality is that the people in their own community understand their need the most. I think the other thing as well is what we've seen is like health on the high streets. So a lot of things being done and working, you know, having that health in the community setting. So it's great to come to a hospital, but there are some community settings where, you know, consultants, doctors, etc., you know, clinical providers can go into the community and be able to treat patients closer to where they live to try and again prevent them from having to kind of come outside, go to hospitals or having to worry about cost and things like that. So those are a few things that I've seen work.
Interesting. Sorry, Barty, you go ahead.
It was just a small example, to cover the fact that if you are doing any digital innovation, transformation, etc., we should look at the impact of the gap. Will not be able to accept that technology because of the barriers we've just talked about. And coming to the other thing about transportation, I mean, I'm not sure if every trust has got this privilege of having their own charity. So I was working in a service quite closely where it was a regional service and patients just could not afford to travel. It was quite at least £100 for a child and a parent to come and access that service. And our local charity absolutely happily supported us with the level of funding where we could support families with their travel costs. So do look at your trust charities if you have a good case to make.
Good, thank you. So various comments coming in the chat, so just trying to pick up at the relevant questions. In terms of those that join late, there will be a recording, so we'll get that sent round after. I guess on top of the innovations we were talking about, I know I think as Marcy mentioned before about the use of chatbots and those kind of innovations.
Yeah, so I think it comes back to, again, that sort of patient-centered care and being able to provide a way for patients to communicate. I think, you know, some of the experience I've had when I've worked within trust and working with outpatients is that sometimes patients don't cancel their appointments, just simply because they don't have time to sit on the phone and wait for 20-30 minutes to get through to cancel the appointment. So, you know, new innovations, we do know that there is two-way text messaging where you can respond and give that information, but there is some work actually happening within certain trusts that are exploring chatbots further, being able to, you know, not only go online and kind of cancel, reschedule, but even ask questions if they're unsure about, you know, where to go, what to get access to. And I think it kind of comes back to some of the points that have been raised already today, is actually these chatbot facilities, some of them are very quite technical, and you can actually change the language and change it to something that works for you. So again, in opposed to having to call up and you're not really confident with your English, you can do that through that sort of digital technology. And I think those types of ways we're seeing has a really successful sort of hit rate, you know, 85% of patients responding using that as a tool to be able to kind of reschedule, and has definitely sort of reduced the DNAs and kind of increased the sort of attendance, which has been fantastic.
Yeah, that's good. And ultimately it's helping manage that capacity as well, because it's not something that needs to be managed by someone if they can get the answer or do that via a digital platform that does it for you. That's good. Barty, any comments on any innovations that you've started using?
So I quite like Marcy's idea of chatbot. I don't think so we are kind of anywhere near trialing that. But with the new digital system that the trust is implementing, which is Epic, it has got a very powerful functionality of having two-way interactions with patients, which is, you have to initiate the conversation from the hospital. So it's for patients to respond, but we think that will enable some of it in terms of reminders, are you coming, etc. So I think we won't be relying on external providers, which itself is a barrier because they are not integrated systems. With our system, somebody has to log onto a different platform to do those reminders and texting. So definitely, I think this is all coming together, and trusts are probably we're thinking of different streams of improvement.
Good, thank you. That's helpful. Conscious we're nearing a time, probably got about 5 minutes left. So just wanted to maybe round up any sort of final points any of the panelists want to bring in or experience want to bring forward that would be helpful within outpatient transformation.
Yeah, I'll just sort of follow on from what was said before, because I've noticed that there's a few sort of intrapreneurs and entrepreneurs within the chat who are thinking of new initiatives to support outpatients. And I think really just a point of information. And yes, we can talk about specific solutions, but actually, I think one of the things that's really important to recognise is where digital is also still a barrier, and where we might create efficiencies in one place, we might create inequalities in another. We've kind of touched on it in terms of you know, who has access to what in terms of smartphones and stuff, but I think there's always, whenever we're thinking of a process, an innovation, a solution around supporting outpatients, having a fail-safe that means that, you know, for example, my personal grandma probably wouldn't be able to engage with a chatbot. So if she didn't, and she was sent a link to engage with a chatbot, she does have a smartphone, but if she was asked to engage with a chatbot and wasn't able to, it's really important that something in the system outlines that that person is not able to engage or hasn't engaged for 48, 72 hours and therefore needs to fall back into the system. You know, we're never going to get to 100% of being able to support people in this way. So I think one of the things I really want to highlight is that, yes, digital is going to enable us, and innovation and automation, all the things I've mentioned today, is going to move us to a more efficient place, but we will never get 100% there. And I think it's the people that are the 100 minus the whatever we do manage to achieve that are equally important that we support. So having fail-safe mechanisms in there to be able to follow up patients with the state-of-the-art, slow, sluggish stuff that actually some people, it's the only way that they can receive care. I think that's still an important thing to highlight. So whenever thinking about implementing a new solution, it's always important to make sure that we're not creating new inequalities and new barriers to yes, a minority population perhaps, but a population nevertheless.
Yeah, I think that's a really important point to make, and it almost comes back a bit to more around patient preference in terms of what is their preference point, but also then trying to steer it down what is the most efficient route for the trust and then for the patient themselves, that is the way they can do it. It's good, thank you. Marcia, any final thoughts?
I think the main thing is to just, if you're not involved in, the digital side of the trust or the departments that you work in, is actually just have conversations, because you'd be surprised how many trusts you go into where they're not actually fully maximising what the trust already has in place that's already been working. So, just making sure that if you've got two-way text messaging, is it switched on for all of your services since we've come out of COVID? Because pre-COVID, when COVID was happening, it was switched off. So just making sure it's active, it's enabled for all specialties and services, and just seeing what you do have and seeing if you're using it to the full of its ability. And if not, having those conversations and getting that shared learning across specialties and different, practitioners to make sure that you can get the most out of what you've got.
Yeah, good. Thank you. That's a good point. Thank you. Barty, any final thoughts from you?
I think the last point I would like to highlight, we kind of briefly touched upon, we think we know our patients, but if you're setting up a major transformation program, have patients on the forum and on the group from day one, and choose the right patients, like what population you're serving, have them from all levels of the IMD groups, to make sure they're representing the needs of your population. NHS is short of money. If we throw money on something that our patients are not going to accept, this is complete waste of our time. So if I can just echo that again, I think that would be my final message.
Yeah, no, appreciate that, and yeah, very good advice. Thank you. Alex, any final thoughts or any questions we've missed to quickly cover off?
That's been really helpful. I think there's been some good practical examples that I think will be very useful for our audience. So really appreciate the panel and their insights and the ideas and experiences they've been able to share. I certainly found it very useful and very insightful.
Good. Thank you. Well, I think that just brings us to the end of time. So I'd like to say a big thanks to our panel for joining and sharing your insights. Both been very insightful, as Alex said, so appreciate that. And thanks to everyone who's joined and those that have joined in with the chat. So appreciate you joining. If you have got any questions, then please feel free to reach out. And I can put you in touch with any of the panelists as well if you want to pick up further conversations with them. So thanks very much.
Thanks for having me.
Thank you, everyone. Thank you.